So we're still talking about hemorrhage, and now we'll talk about the practical aspect, the management. The management of hemorrhage is most important in the actual takeaway from this lecture. If you remember the management, I would be served. My purpose would be served. So we'll talk about the identification of the hemorrhage and the resuscitation attempts, obviously. Then we'll talk about the hemorrhage control, and finally the damage control resuscitation. I'm not going into the details at this point because we'll go into the details as the slides progress. So first of all, you have to identify the hemorrhage. So in external hemorrhage, it's obvious from where the hemorrhage is taking place, but still you need to make sure that this is the only source. For example, you see a patient who has stripped on something, and that patient comes to you with an obvious, say, hand injury, and that is bleeding. You should always ensure that the rest of the body does not have an injury. So, in an obvious injury, you should always ensure that there is no unobvious site of bleeding. So in an external trauma, the bleeding site is pretty obvious. It is difficult to diagnose and conceal hemorrhage, but again we can take the help of various investigative modalities. So any shock is hypovolemic unless proved otherwise. So tie that with you, keep that in mind always. If you see a patient with hypovolemia, the first thing that should come to your mind is hemorrhage. The hemorrhage is the cause of hypovolemia unless it is proved otherwise. Again, hypovolemia is always due to hemorrhage. Again, once proven otherwise. So hypovolemia and hemorrhage, they go side by side. So whenever you see a patient with hypovolemia or hemorrhage, you should consider the other in that patient as well. So the resuscitative attempts. So direct pressure over the site of external hemorrhage, what does that do? It presses on that damaged area from where the blood is oozing out, and as a result of that pressure, there's collapse of the vascular wall. The collapse of the vascular wall prevents further leakage of the from that vessel. So you should always apply direct pressure if you can. You should assess the airway and breathing because you're managing your patient now. First of all, you should try to stop the bleeding, and after that you should resuscitate your patient by checking the airway, by checking the breathing. Now always go for large bore IV access because you might have to activate the MTP, the massive transfusion protocol. Even if you don't have to use that, you might have to resuscitate your patient with a lot of fluids. So using large bore IV cannula, you should be ready and prepared for that. Now blood is drawn at once so that you can cross match and type the blood, so that you can send your investigations as well, and request for emergency blood. So the request for emergency blood is very important. The doctor has to shout MTP, and he should make it clear what he means by MTP. So you should always activate the massive transfusion protocol in a rapidly hemorrhaging patient. So now the identification of site of hemorrhage is very important. So first of all, you identify the site, then you choose the operation, or then you choose the procedure you want to do. You can choose a surgical procedure, angioembolism, or endoscopic approach, whatever might be necessary and whatever might be available. So the necessity and availability both need to be kept in mind while deciding the surgical aspect of the management. If you have an endoscopic suite that is well equipped to handle it, very well. If you happen to have the angioembolic unit, then very well. If not, you can go for open surgery and you should try to manage the bleeding. Once you're getting there, once you're taking your patient, during that you should always examine the nature of blood. It is fresh. Is it fresh? Is it not? Is it black? Is it red? What type of blood is it? It is tinged, not tinged. it is melina, it is fresh, you should always assess the nature of the blood. Then in shocked patients, the external injury signs suggest the internal hemorrhage. So you see a lot of injury to a patient, but no obvious hemorrhage in that patient. The abdomen is tense and tender. That is a sign of abdominal bleeding. So always trust your gut. Always trust your senior. Whenever you suspect bleeding, always inform the senior doctor and voice your suspicions. So you might be wrong, but you might just save your patient. Again, the hemorrhage in the body cavity should be included with the rapid investigation. The fast scan should be done. Ultrasound of the belly and the abdomen must be done so that the bleeding in those regions can be excluded. Then there's diagnostic peritoneal aspiration or rapid bedside test. So either of them can be done depending upon your conditions. And finally, if there's no bleeding, then the methodical workup and the definitive workup should be done. So once you have identified the bleeder, you have to stop the bleeder. So for stopping the bleeder, you can use any of the surgical means you have. While doing that, you should examine the patient for the type of blood that is there. You should examine the amount of blood that is being there. You should consider the possibility of a concealed hemorrhage as well, and you should rule it out by investigations and tests. So also a very important point is to note clues from the previous history. So previous history of the past medical history is very important, and should note clues. You should ask for any previous episodes like these. You should ask for aneurysms or use of NSAIDs for GI bleed. So what types of investigations you should use? The investigation you should use are chest x-ray. Obviously, the chest x-ray has a lot of functions, it helps a lot. It gives you an idea of the patency of your airway as well as the patency of your lungs. At the same time, it also excludes any bleed. Now, pelvis x-rays just to make sure that there are no bone breaks and there are no fractures, and then there's abdominal ultrasound to rule out any blood in the abdomen. So the method of hemorrhage control, you should move your patient directly to the OT. It can also be an endoscopic unit, whatever the case may be. Now, surgical and anesthetic support is required to your patient, and patient monitoring during your surgical procedure is very important. Now, the availability of required equipment should be there. You should always take your patient to a proper surgical suite which has all the necessary equipment that might be required to resuscitate your patient. Now, the hemorrhage should be controlled rapidly. You should prevent patient entering the triad of death. So what was the triad of death? Triad of death was the acidosis, the coagulation, the metabolic acidosis, hypothermia, and coagulopathy. And this triad of death, it ensues when there is extensive hemorrhage. So you should try to control the hemorrhage as fast as possible. You should always limit your investigation. No unnecessary investigation should be done unless your hemorrhage has been settled. So you take the blood sample, you type and cross match it. You should do the basic labs, but you do not go for extensive lab work because you have to manage your patient first. So there should be minimization of duration and severity of shock. This can be done by minimizing your investigative work and rapidly acting on your gut and trying to resuscitate your patient again. This is the triad of death, which comprises of hypothermia, coagulopathy, and metabolic acidosis. Once the patient gets into this triad, it's very difficult to resuscitate and revive your patient. Now, there should not be prolonged attempts at resuscitation because it furthers the hypothermia. The resuscitative fluid must be warm enough while giving to the patient so that hypothermia does not ensue. There's dilution of the clotting factors. We've talked about it before. The clotting factors are diluted due to transfusion of various fluids, the transfusion of blood and blood products. It leads to dilution of clotting factors. You should always try to correct the coagulopathy. And for the correction of coagulopathy, you need to find out the cause. What exactly is disturbing the coagulation? You should always rule out any infective or viral processes, and you should always give prophylactic medicine against it. Now, this aids in surgical hemorrhagic control. So, when a patient is not under any inflammatory response, the surgical hemorrhage control becomes easier. So, always tend to find out whether there's an infectious or an infectious element to the hemorrhage, to the entirety of bleeding. Now, the surgical intervention you might use a tailored procedure. The tailored procedure might be specific to your condition, or you might use a general procedure that is used for the various procedure for the control of bleeding in that area. And if you use a tailored procedure to control bleeding, you go in, you control the bleeding, and you leave everything out. You just control the bleeding and you let your patient heal, and then you go in afterwards to correct whatever deficit has been created. This is known as the damage control surgery. So, a damage control surgery is a tailoring operation to match the patient's physiological needs. It's a staged procedure which prevent the physiological exhaustion. So you're trying to break the triad of death by meeting the patient's physiological needs, and this is known as the damage control surgery. It is limited to stopping the bleeding only and to control the sepsis. All the other things are left out. Once the patient gets better, you get into the patient again and you improve the patient's outcome. There's delay in definitive repairs. So damage control surgery has the following steps. First of all, you arrest the hemorrhage, then you control the sepsis. Then you protect from further injury, and you don't do anything else. So control the hemorrhage, control sepsis, prevent further injury, and that's your damage control surgery. Damage control surgery is life-saving in war zones, and damage control surgery is also recommended in triage in large natural disasters. Now, the resuscitation in the patient, ensure the patients are fully resuscitated. So the resuscitating team should make sure your patient is completely and fully resuscitated as per their desires and wishes. This reduces the incidence and severity of organ failure. So once a complete resuscitation has been done, the incidence of organ failure decreases. So the hemorrhage control, in hemorrhage control, you should actively resuscitate your patient. First of all, you have to control your bleeding by damage control surgery or whatever means you might use. Once you have controlled your hemorrhage, now you should aggressively resuscitate. You should adequately warm your patient. You should correct the coagulation defects if they are there. You give prophylactic antibodies. Note the dynamic fluid responsiveness. Very, very important. You see how the patient is responding to fluid, and there should be vigilant monitoring of endpoints of resuscitation. We've talked about endpoint of resuscitation once before. You should always keep an eye out for your patient. You should always see how your patient is responding to your resuscitation, because the better your patient is responding to your resuscitation, the better are the chances for your patients of survival in getting through this ordeal. So what is damage control resuscitation? It is a combined concept in which you're performing the damage control and you're resuscitating your patient as such as well. So let's see how you put it into proper words. It's a combination of concepts for management of trauma patients with active hemorrhage and is known as the damage control resuscitation. So you're performing the damage control, you're performing the resuscitation. In damage control, you are stopping the bleed, you are preventing sepsis, and you are preventing further damage. That is your damage control done. In resuscitation, you're ensuring the endpoints of resuscitation are there. You're ensuring there are no complications. You're ensuring sufficient fluids are given to your patient. You're ensuring you're monitoring your patients adequately. So you're damage controlling, you're resuscitating at the same time, and this combined approach is known as the damage control resuscitation. It reduces the mortality and morbidity in patients with trauma, obviously, because you're giving the best care to your traumatic patient, and this reduces the morbidity and mortality. It may be applicable in other forms of acute hemorrhage as well. This is primarily used in war zones, but you can also use in other forms of active hemorrhage. So there are 4 strategies. You anticipate and treat acute traumatic coagulopathy. So you keep an open mind, you have an idea, you keep that in mind that acute traumatic coagulopathy might be there. So you preemptly, you anticipate it and you treat it. Then there is permissive hypotension until hemorrhage control. So you allow the hypotension to develop in your patient until your hemorrhage has been controlled. So you do not go for dilutional effect of the coagulative pathways, the coagulation factors. What do? You allow hypothermia to set in for the time so that you can control the hemorrhage. Once you have controlled the hemorrhage, you can resuscitate your patient. But while resuscitation, you should limit the crystalloids and colloid infusion to avoid dilutional coagulopathy. The crystalloid solution also causes acidosis, so you should keep your hands slow on that. And finally, the damage control surgery is done to control hemorrhage and preserve the physiology. So these are the 4 steps. You anticipate and treat for traumatic coagulopathy, you permit hypothermia, you limit crystalloid and colloid use in damage control surgery. These are the 4 parts of damage control resuscitation, and this improves the mortality and morbidity of your traumatic patient. So this was all about this section. Again, this was the takeaway section. I need you to remember this and keep this in mind whenever you're resuscitating your patient, because that is what you have to do. For further such lectures, keep watching sqadia.com.